So I can really tell that helping a patient to stop smoking is a really important part of COPD management. Are there any other management tools?
Yeah. Actually, let's review some of the management tools we have for stable COPD patients. So, in this portion of our guide, in this segment, there are specific things that we're going to do and look for, okay? So, let's pull it up right here. There's a great diagram I want to show you. So that once COPD has been diagnosed, there are effective management tools that should be So once COPD has been diagnosed, effective management should be based on an individualized assessment of current symptoms and future risks. So that means to reduce symptoms, we're going to look at how we can relieve them, how can we improve their exercise tolerance, as well as improve their health status. Now, to reduce their risks, we're going to attempt to prevent disease progression, if we can, as well as prevent and treat their exacerbations and reduce mortality. So these goals should be reached with minimal side effects from treatment of particular challenges in COPD patients because they commonly have comorbidities that also need to be carefully identified and treated. All right, so there's a few more things that I would love to go over with you. Let's actually review a segment here from Table 6. So, non-pharmacologic management of COPD according to the individualized assessment of their symptoms and exacerbations is shown here. So, Mrs. Tubbs, is documented as Mrs. Tubbs is documented as a patient in Group B. So she has certain essential, recommended, and local guidelines for her. And since here she's in B, for her essential portion, we're going to encourage her to engage smoking cessation, which can include pharmacologic treatments, as well as pulmonary rehabilitation. Now, it's recommended that she have physical exercise or physical activity, and depending on her local guidelines, she may need a flu vaccination or a pneumococcal vaccination as well. Now, being in Group B, as she is here, her first choice, as indicated on a chart here, shows that for her, her first pharmacologic drug of choice is actually a long-acting anticholinergic, or a long-acting beta-2 agonist. So let me describe for you a little bit about what that is and what that means.
Okay.
So being in Group B, Mrs. Tubbs' first choice is a long-acting anticholinergic or long-acting beta-2 agonist. Her alternative choice, as you can see here, is a long-acting anticholinergic and long-acting beta-2 agonist. Other possible treatments for her could include a short-acting beta-2 agonist and or a short-acting anticholinergic. She also has the option of theophylline. So a little bit about what those drugs are: anticholinergic and beta-2 agonist. An anticholinergic will relax, and if I can use this diagram again for you, it's going to relax and enlarge or dilate the airways in the lungs, making it easier to breathe. And we call those things bronchodilators. Dilate to open, right? They're going to help protect the lungs from spasms that can suddenly cause the airways to become narrower. And that's what we talked about in her assessment. She had bronchospasm. It's going to constrict those airways, make the lumen smaller, okay? And these anticholinergics can also help reduce the amount of mucus that she's going to produce. And, for COPD patients, you have to remember all that mucus clogs up these airways. It doesn't just run to the bottom of the lungs. It makes the lumen smaller as well by lining the airways, decreasing the amount of available airflow space. So for her, a possible drug choice would include atropine, or by its trade name, atropine. And for her, she can have a dose of about 0.025 milligrams per kilogram and a 2.5 milliliter normal saline solution. And she can have that with a nebulizer every 6 to 8 hours, okay? Now, a beta-2 agonist, I'm just going to hold on to this because we're talking about another bronchodilator. A beta-2 agonist is going to relax the smooth muscles. Now, this is the cartilage, so we're not really going to see any muscle on that model, but it's going to relax those muscles, and relax smooth muscle lining in the airway so that they carry air to the lungs or those bronchial tubes. And that will allow them to stay open longer, making breathing easier. I'll show you a picture right here what that looks like. We don't have the model in front of us. See how it's opening up when you give the medication. And the common drug that she can use, commonly known as salmeterol, or by trade name Ceravent, it can be given to her in a dose of about 50 micrograms or one inhalation twice a day. It's one of the options. Now, a combination of the two, right here, can be found in a drug combo called fluticasone and salmeterol, or by its trade name, when you see commercials for this, Advair. And this has a dosage of about 2 inhalations twice a day. Okay, so an example, one of the last ones it mentioned, was a short-acting beta-2 agonist. One of our options is albuterol, and it also has many trade names, one of which is Proventil. So Proventil can have a dosage of about 1 inhalation every 4 hours or so. Now, an example of a short-acting anticholinergic is ipratropium bromide, and it has a trade name called Atrovent. Now, this can be given at a dosage of about 2 inhalations every 6 to 8 hours or so. Okay, and finally, the last one I mentioned that sounded kind of funny is theophylline. Now, that one is another bronchodilator, and it can be given at a dosage of about 5 to 10 milligrams per kilogram per day. So those are some of her medical options that she has available. Of course, as therapists, we are allowed to not prescribe them. No, we are allowed to administer those to her as needed and as according to a doctor's order. So for COPD patients, a lot of them will need some type of drug therapy just because it's such a progressive disease that needs some management. So I do want to go over just a few more things with you, but Ms. Lucy, I think that this information might have been quite a bit, but you seem to be so interested in absorbing it all so well. It's probably time for Ms. Tubbs to have her breakfast tray removed, so we might be able to go into her room now and start our treatments and assessing her. So we have some data here, and we'll be able to access it in her room as well in case you forget some of the x-rays and some of the details and all those things. But do you have any questions for me?
No, you've been so thorough. I really do appreciate it. I really feel like I have a better understanding of the role that respiratory therapists would play in helping the patient stop smoking and in their COPD management. So I'm really looking forward to the rest of the day.
That's awesome. Well, Lisa, you know what? Let me just log out here. And you know what? Let's get started. I think you'll do great. I'm excited for you. All right, let's go start the rest of our day, okay?
Okay.
Awesome.